exploring the benefits of early palliative care for family caregivers of patients with advanced cancer. The senior author of this presentation is Dr. Marie Bakaitis, the Marie L. O'Corin Endowed Chair and Professor at the University of Alabama School of Nursing in Birmingham, Alabama, and she will present the findings.
Thank you, Dr. Gans, and I want to acknowledge the presenting author on Tuesday, Dr. Nick Dionne-Odom. So I appreciate the opportunity to present the results of our National Institute for Nursing Research funded ENABLE-3 trial, and this acronym stands for Educate, Nurture, Advise Before Life Ends. In the ENABLE study, we enrolled advanced cancer patients and their family caregivers as a dyad. And today, I'm only presenting the family caregiver outcomes. Of the 13 million cancer patients in the U.S. Who live with advanced disease, many will require up to 8 hours of assistance from a family caregiver. These family caregivers are vital but often neglected members of the cancer care team, providing essential care to the patient, including symptom management, physical, emotional, and personal care support. These family caregivers can experience psychological distress equal to and sometimes greater than the person with cancer. The family caregiver stress can lead to poor physical health and even a higher risk of death. This burden of family caregiving is truly an under-recognized public health crisis. Unfortunately, few interventions have been found to obviate family caregiver burden, and the palliative care services, though potentially beneficial, are often provided very late in the cancer trajectory. Therefore, we developed a parallel family caregiver intervention to accompany our early evidence-based patient intervention. The primary aim of the ENABLE study was to determine the effect of providing palliative support to a family caregiver in conjunction with standard cancer care. We hypothesized that immediate intervention would demonstrate improvements in quality of life, depression, and burden. This slide illustrates the study design, a brief description of the caregiver intervention, and outcome measures. And I call your attention to the schema. In our study, we asked patients to identify a family caregiver defined as someone who knows you well and is involved in your medical care. The patients and family caregiver were randomized as a dyad to begin the intervention either at the time of diagnosis, the immediate group, or 12 weeks later, the delayed group. We then collected our outcomes data at baseline, 6, 12, 18, and 24 weeks, and then every 3 months thereafter. As you look at the box describing the intervention, you'll note that we delivered ENABLE primarily as a telehealth intervention to meet the needs of our rural underserved population. However, the intervention began with one in-person palliative care consult visit, which the family caregiver was encouraged to attend. The telehealth component consisted of 3 structured phone calls with a nurse coach using a guidebook that we called Charting Your Course. As shown on the slide, each session covered topics directed at both supporting and empowering the caregiver. Our primary outcome measures are listed in the box below, and I'll now share the most important results of our study with you. Keep in mind as I share these results that in all measures, lower scores are better. In the first of these 2 results slides, you can see that 12 weeks after both groups started the intervention, the immediate group had a lower quality of life score corresponding to less trouble or better quality of life at a significance level of 0.02, and that's shown in green. They also had a lower depression score, again lower is better, at a significance level of 0.006, and I'd like to mention that the clinical cutoff for depression is at 16, and so you can see that the delayed group was above that clinical cutoff. In other words, a clinical depression diagnosis could be made. And there were also favorable trends towards lower caregiver burden, and that's shown in tan at a significance level of 0.10. We confirmed these results in family caregivers of the patients who presented the most burden, those who ultimately died while on the study. In the immediate group, we again found a favorable statistical trend of 0.07 of a lower or better quality of life, shown in tan, a lower depression score at a level of 0.02, and please note the family caregivers at 12 weeks rating 18.6 in their depression score, and a favorable trend towards lower burden, shown in tan, at a lower level of burden at 0.01, shown in green. To summarize, this is the first palliative care study to include family caregivers and investigate this important issue of timing. Our results demonstrate that family caregivers' quality of life, mood, and stress burden were improved in the groups that received the intervention closest to the time of diagnosis. So we concluded that offering concurrent palliative care to patients and family caregivers while patients are still receiving cancer treatments would provide family caregivers with the greatest benefit. In our future studies, we are investigating how these results will hold up in a more racially diverse, underserved population. Thank you.